Good morning, everybody. I have a dilemma now. The dilemma is when you open a public speech, you begin with some of the niceties about acknowledging everybody, you name everybody, and I follow all that. And the second thing is that the second way to begin a conversation is the typical UN statement, all the protocols are being observed. But I cannot escape by saying either of this because there is a reason behind it. I was a student of this college, and when I looked around, and I was thinking that maybe I studied about 100 years ago. So don't ask me when did I study here. I completed my graduation from here. I began my professional life from here, and 3 years I was in the hostel, Tagore Hostel, and I tried to figure out where is that building even. So unless I acknowledge that, and also I want to say one more thing. When I was a student here, I used to run away when I see the principal or the manager. So from there, I'm sitting with them and I'm talking to them. It's a privilege. And thank you very much for that privilege. And it's a privilege to talk about a subject which is very important. I'll come to that why it's important. When you talk about, when you look at this subject, global health for all, then public health, social work. So there are 2-3 words are floating around. So let me begin with introducing those concepts. So health for all is a slogan. And this slogan, first time it came into the global arena was in 1978 at the Alma-Ata Declaration. And health for all had another adjective, health for all by 2000. So today is 2024. So it is an agenda set by for 2000, and we are already 25 years is gone, and still it's an unmet agenda. So that's the one reason why we have to look at health for all as an important thing. The second thing, when we suggested the idea that health for all, there is no social media. So who set the agenda? How agenda is being set, it's also transformed. Earlier, the ideas are set by universities and institutions of higher education. Or universities, institutions of higher education are the custodian of ideas. The idea of public health was as custodian of some UN agencies, academic institutions, but that transition occurred. Today, the health-related agenda is set by, negotiated, discussed on social media. And we assume our ideas about certain key principles of society, how it is transformed. I'll give the health is, public health is a critical example of how the idea of creation is hijacked from the universities or higher education to public media. It's a good thing, at the same thing it's a bad thing. The bad thing is that institutions, they have an informed opinions and also debated opinion. But social media, nobody is challenging creating the ideas. The typical example about the situation of health. Health is a state subject. Health in the federal setup, health is a state subject. So state and the health has got an interesting interaction, interesting intersectionality. That's another word we missed in between. And the federal government got certain health agenda. State government has got an agenda on a national framework. Then there are global level, international level. There are different levels this is being discussed. So in my presentation, and also I just want to briefly mention about why I suggested, when I accepted this speech, from when I left Devgiri College, from there onwards, somehow I had driven into the issue of health, medical anthropology, social anthropology. My PhD, I looked into the mental health of refugees. So then I moved on that way. So somehow, the health of different population was, I didn't even realize that I was following the health of different population in different setting. And I also had opportunity to create some of the institutions who contributed towards public health education. And one thing I just want to highlight out of many experience, I had an opportunity to create a scholarship about 150 medical doctors from Afghanistan to bring them to India for a master's program in Jodhpur National University. So out of that 180 scholarship, almost 100 scholarships were used. They finished their courses, including about 15 women doctors from Afghanistan. And today, Afghanistan ministry is run by my students. I don't know if it's a good thing, bad thing. And in that capacity, I had opportunity to visit most of the provinces in Afghanistan many times. That's a learning experience. So I mentioned that, and for mention about being passionate about a subject, my professional passion is about public health. So I'll just come to the next point that way. And what is the objective of my keynote presentation? When I talk to you, I hope I can help you to understand public health in a different perspective, a critical perspective, and also you can look at social work, professional social work from a different angle, the angle of public health, but I add an adjective called critical public health. I'll come to that point. That's what I want to spend most of the time here. And I want to talk to you about 3 themes today. The first theme is about introducing the evolving subject of public health. Public health itself is transformed. And the second is I just want to explore the convergence of public health and social work. The second theme I want to explore. And also practicing public health. How do we practice public health? And I try to bring examples from women's health in Kerala. So these are the 3 thematic issues I want to explore. Within the theme, there are some sub-themes are coming. I'm not explaining it right now. So broadly, these are the 3 themes I want to introduce and discuss about today. When we talk about health, public health, there are different genera, there are different branches of public health. So let me briefly mention that. That is the public health as we hear normally. Then there is something called international health. Then there is a global health, population health, and I introduce critical public health. So all this has got meaning. This meaning has an implication on how do we practice public health and what areas you can capture and to look at the convergence from the social work point of view, from the professional social work point of view. So this is the second aspect of when I try to expand my theme. And public health, in any academic presentation, you have to begin with a definition because academicians are very good in defining a subject. So I cannot escape without giving a definition of public health. In the essence, public health is any organized effort to make changes in the health and well-being of the population. That's a basic thing. But then this has got another implication. You also have to create the environment for good health and well-being. Again, we have to look at any ideas critically. The critical examination comes with what we hear about the dominant ideas. Dominant idea, we have a good health, we are number 1 in health, and we are a model of health. These are some of the prominent discourse about health here. But I'll try to take you through some of the dominant themes and what is the story behind it, applying a lens of critical public health and particularly looking at the concept of equity and the concept of justice. The health is about justice and public health is about looking at equity, not equality. So this is an introductory idea about how do we look at public health. And there are details about now, let me briefly tell you what is international health. International health has got a very interesting dynamics. International health is normally associated with some of the donor agencies. And the 3 dominant donor agencies was, not is. One is USAID, second is the DFID, third is USAID. These are the 3 major donor agencies of public health. Then there are World Bank, Asian Development Bank, all this. But these 3 institutions, normally they refer public health as international public health. When you use the word international, they refer to some of the countries, not necessarily all the countries. For them, international means the countries falls into their diplomatic arena. USAID has got a very particular diplomacy in relation to health. DFI, the British Foreign Aid, has had a particular angle and definition of bias. But interestingly, all these three closed down. And today, international health is almost weakened in that idea. And also there are international, when you use the word international health, there are schools of public health, international schools of public health, not necessarily global health. This politics is also important to remember when you look at, from a social work point of view, what ideas you should pick from public health. And again, international health is transforming because major donor agencies are withdrawn. So what could be its implication? This is the one thing professional social work also might look into it. And the second aspect is about global health. The global health is about the health of the globe, everybody, 194 countries in the world, and the custodian of the global health is World Health Assembly, whereas custodian of international health is DFID, USAID, OSAID. So this was the difference between international health and the global health. This also got implication in social work, I'll come to that. And next is about population health. Population health is health of some population, not all the population. Health of women, health of Adivasis, health of people who are in the settlements. So health of some people is you're talking about population health. So population health and social work, you think about it, what you pick and choose. So we notice that international health, global health, population health, and the custodian of each one is different. And again, social work is a co-traveler of all this on a different level. And my passion is about looking at health critically. And so I was introduced that I did one of the top 20 international public health journal called Critical Public Health. And Critical Public Health, I'm not promoting my journal, by the way, I'm just introducing. The Critical Public Health, we approximately publish about 200 papers in a year. And in that process, I reject about 400, 500 articles. So this is to just give an idea about the theme or agenda setting on a global level, on what agenda is being promoted to critical public health. I utilize that platform very seriously through my editorial. And again, there's a reason behind it, why I'm highlighting it, I'll come to that. The critical public health is looking at public health from a critical lens. And as I mentioned earlier, look at the issue of justice, look at the issue of equity. Whether any public health program, it is meeting these two criteria. Is it equitable? Is it forming justice? And you try to apply this to any health program, any government program, and the state health as it is. So these are the two principles from a critical public health point of view. I'd look at it. And I'll come to that, how do you apply it? And my next theme is about the convergence of public health and social work. Because this theme, the entire session is about what are the converging areas and what are the diverging areas of public health and social work. So one of the convergence is about some of the ideas. Social work is committed towards the issue of transformation. Social workers are transformers. The capacity of social work, one of the major capacities, the transformative capacity of a profession. Dayabai is an example about it. How do you transform? She is a trained social worker, but then she moved on to the transformative function of the social work. So this is the one thing sometimes when you study, you may not see the transformative potential. And how do you do the transformation? On two levels. One is on individual level, you do the transformation, and also community level, you do the transformation. But on a practical level, this transformation takes place. But when you combine this with public health itself is struggling. The concept of public health itself is struggling. Professionally, it is struggling. There are reasons behind it. For example, in Kerala, we have more than 100 schools of social work. It's very significant to understand that number, whereas all over Kerala, we have only 3 schools of public health. Because there is a reason behind it, public health is not let it go. Public health is not liberated from some forces of understanding public health. One of the major transition of public health is increasingly becoming demedicalized. Public health is not a medical subject anymore. But at the same time, I would say that that transition is not happening automatically. There are, when you look at the equity of knowledge, when you apply the same principle here, the equitable distribution of public health knowledge is not smoothly transforming. It's mostly because of how knowledge is created and who are the custodian of knowledge. And this is very important in the Kerala context, because in Kerala, the critical mass who should look at public health is very limited. I would even make a very radical statement that the critical body of people and knowledge about public health is deliberately controlled, and the agenda is set control. And also I invited Dayaba's experience. She looked at one of the health issue in her Kasaragod struggle. It was a health issue from a public health point of view. She moved to, into health issue, public health issue. But that public health issue was not got the attention in the Kerala level. This is because of how the knowledge is being created, how the knowledge of public health is being created. And because of that, I would congratulate the organizers for looking at this critical issue, to creating a critical body of knowledge, critical body of people who look at public health in a entirely different frame of reference. That is a public health reference. Then I mentioned about different genera of public health and also critical public health. And the convergence, again, certain value level. The values of equity is shared by both groups. Values of fairness is shared by both body of knowledge. But the difference comes in, and in social work, you do this through practice. Public health is done through analysis. Analytical capacity and the transformative capacity by doing things, both are complementary. At the same time, both has got its own limitation as well as its own capacity. In public health, one of the limitations is lack of theoretical foundation. Public health is practice oriented. In that process, the theoretical, creating the theory of social work is somehow not catching up. Whereas in public health, we developed a theory. Public health theories are created. We looked at the issue of how public health is transforming from a decolonizing perspective. Public health ideas is no more a colonial mentality of health. And the public health is transforming from demedicalizing through an independent body of knowledge, not anymore defined by medical profession. So these are some of the transition on an idea level. Whereas at the practical level, public health is still struggling. To understand that, you have to remember that health is outside the hospital. The factors, the variables contributing towards health are outside the hospital. You treat the patient inside the hospital, you work with the community to prevent diseases, to improve the well-being outside the hospital. This major distinction is an important issue to keep professional social workers in mind. So even though you have the social workers, some of them you work with the hospital, inside the hospital, the major experience of professional social work should be outside the hospital and also working with the community. Social work methodology, that working with the community is one of the major methodological uniqueness of social work. So maybe this is what public health I to borrow in. And also, let me just jump the gun. My wish list is that during this process of discussion, maybe the Averi College may look at creating a program on public health. It could be a certificate, diploma, but create the seeds of creating professional body of knowledge about professional public health, and also creating practitioners of public health. So I hope this institution may look into that area a little more seriously. And I got the attention of the principal and also the manager. So I forcefully advocate for the need for looking at professional social work as one of the future of Devagiri, and two areas. One is the convergence area of social work and public health as a standalone program. Maybe I would strongly recommend to look at the future of education. These are the two areas maybe you should take into very seriously. And incidentally, I said the same thing at Rajagiri College about a couple of days ago. So I had an opportunity to talk to some other universities as well. In Kerala, there is a need for a public health revolution and public health transformation. And what we see about public health is not what actually happening. I'll come to with example and data. And let me come to my third point. It is about practicing public health from a Kerala point of view. And we heard that Kerala got excellent education. I agree, there is no challenge, there is no argument about it. And also life expectancy is one of the highest in Kerala. And we have a wide primary care coverage. I put that word, wide primary care coverage, quote unquote. So let me challenge that idea. Kerala has got 941 panchayats. Out of 941 panchayats, about 300 panchayats, there is no facility for the bed for the patients. So the primary care is actually critically challenged in Kerala. If you get a primary, because there is no primary care, universal primary care, through, in Malayalam, 300ഓളം പഞ്ചായത്തിൽ കിടത്തി ചികിത്സിക്കാൻ സൗകര്യമില്ല. That's the reality in Kerala. And this reality has got major implication. What's the implication? All these PSCs, they close by 12 o'clock. If any disease, any accident happen, you have to go to the nearest Taluka hospital. And Taluka hospital is it's a cluster of about 14, 15 panchayats. And I looked at all the panchayats, the data in the Kerala, including the Taluka level. In none of the talukas got, all the panchayats is covered by PHCs. And the CHCs is increasingly being implemented. So this is one of the formula, what we hear through social media is, we are number one in primary health, we are not number one in primary health. Look at the data. This is a critical way of looking at it. And the second is Kerala rank in Human Development Index. I'm not challenging it. And I'm not challenging the entire the assumption. Some of the critical assumptions I'm challenging it, and I'll bring the data. And also the statements I make here, I'm not giving the data, most of the data here. If anybody is interested in following up with the data, I'll be able to give them exact data and references. You can contact me later on. And by stating these 2 or 3 facts, I would say that Kerala is a very interesting example of looking at how primary health or public health is being practiced here. And also let me make one just brief clarity about when you talk about primary care and primary health. I make a distinction between these two. Primary care is about providing care and treatment and support, whereas primary health includes the prevention part of it. When you talk about primary care, largely the prevention aspect is missed out. This is not only for Kerala, national level. The investment in prevention, all sector, all layers are moving out. And this is also another interesting thing is that the concept of public health is public responsibility or a public right. But that right, that idea itself being transformed to the people are considered as they are the consumers of health. A right perspective to consumer perspective. Consumer means you pay for your services. This is a major change is happening in Kerala and national level. And this is also, let me look at the data. About 70% of the deliveries in Kerala is taking place in private sector. And am I crossing the time? Sorry. Please. And the 70% of the delivery is taking place in Kerala in private sector. This is an interesting economic impact. Each delivery, minimum 1 lakh rupee. And in the Kerala cultural context, the first delivery, the പെണ്ണുങ്ങളുടെ വീട്ടുകാര്, they pay for it. Second delivery comes to the boy's family. And when I did my field work, I noticed that most of the young families at the age of 28, 30, they are in debt. The second delivery, they have to take a loan, 18% interest rate. And you can ask your friends and relatives. This is economic transition take place. And before the first child go to the school, they are already in the debt, then they have to get another loan for the child's education. So the economic implication of privatization is important. And this privatization also happening in a different level. The privatization is happening because of the deliberate policy intervention by the state. I'll come to that. You may be shocked to hear that. The Kerala budget, 4% of the budget is for public health. I mean, health altogether, including prevention, treatment, and the petrol for DMA, and also the special payment. All this under the 4%. But according to the WHO, unless you have 10% of the budget, you may not be able to make any impact at the area of primary care. So this is the financing of the public health. National level also interesting thing. National level, national budget, the health goes to approximately 2%. Of the national budget, 2% is that's what the actual allocation. Out of this 2%, 1.8, 1.6% is actual implementation. That's what you spend. We don't spend more than that. So unless the state decide, we are going to promote public health as a public right, this is not going to change. This is a major area. What is the level of investment in health is one of the critical questions to ask. Unless this is go to other level, and people immediately ask, are there any other countries doing it? There are many developed countries are doing it, but people say that people from the United States come to Kerala for treatment. But remember, US is a privatized healthcare, not a public healthcare. US doesn't care that health is a human right. Human right is not part of the vocabulary. Anyway, I'm not here to criticize the US healthcare, but that model is totally different. The insurance agent is deciding what treatment you get, not the doctor. Doctor may prescribe, but the insurance agent says, no, sorry, this is not covered by insurance. So this is a way, thank you. And this is the way our health system is moving. And why I'm raising this issue is that you have to apply a critical lens looking at justice, equity, and look at any program, is it equitable? Take the case of, again, women's health, you talk about it. In Kerala, there are about 46% of all deliveries are cesarean section. And you may ask, so what? Number one, WHO is saying if it's more than 14%, that's a serious reflection of health system weakness. This is also linked with financing. But again, we try to unpack it. In Kerala, 41% of the surgical site infection because of the cesarean section is up to 41%. WHO is saying 4%. If more than 4%, it's a critical issue. Again, when we try to unpack the issue of cesarean section, why the large number of cesarean section? Kerala, 45% of all women, they utilize the tubectomy as the preferred method of family planning. There are different methods of family planning, but women are used to take tubectomy as a major route of permanent contraceptive. Because the kind of advice they receive, the kind of information they receive, many of the doctors, they'll say, okay, go for the, even family members, they'll say, go for a tubectomy. At the same time, there is another part of it. If you look at equity lens, less than 1% of the men are involved in vasectomy. That's a very basic surgical procedure, not even, there is no need of anesthesia. So look at the major surgery minus minor surgery. It's not even a surgery, it's a procedure. That's what they call it. It's not a surgery, it's a procedure. But in Kerala, last year, entire district of Ernakulam, only 2 vasectomy took place. I can give you all the district, how many vasectomy took place. This is a deliberate policy of family planning burden is on women. Just apply the equity principle. Again, you come to that. In Kerala, we don't employ midwives anymore. There is no midwives in Kerala. But all over the world, midwives is the one who holding the hand of pregnant mother. They are the one who give the advice about what are the contraceptive choices. But that particular information is deliberately withdrawn. And this is actually one of the major reasons for women's health in Kerala has got, there are different issues, I'm not getting into detail. The advice, independent advice they are not receiving. They receive the advice from OBGYN. And in my fieldwork, I asked about what is your preferred place of delivery. And nobody said government hospital. But at the same time, when you look at the variables and the parameters, more women are dying because of the antenatal care related complication in the private sector. We don't look at the number. Again, I'll conclude by that looking at the number. We have MMR, maternal mortality rate is one of the lowest in Kerala. Very good. And we have about 15, 13. But who are these women die? These 15 people who are die, look at that. They are from Adivasis. They are from certain districts of Kerala. Same about infant mortality rate. We have 5 infant mortality, we reduced into that. That 5 itself is an estimate, not the actual number. And who are these 5 children dying? This is what question we should ask, not the 95 children saved. These 5 children, 3 from the Attapadi region. One particular location we are talking about. So again, when you look at Kerala is one of the highest abortion rate among teenagers. When you look at teenagers' abortion with infant mortality, there is an implication. And also Kerala has one of the highest level of stillbirth. Look at another data. When you look at all this data together and apply the lens of equity, we can see that there are critical issues coming up. And this is another area, the convergence of social work and public health the advocacy opportunity. Maybe social work advocacy can learn from public health questions and probably looking at a common syllabus, common approach towards that. And the public health will not be liberated soon, I can see that, but the social work is establishing as an independent profession. There's a Kerala Association of Social Workers, and independently there are 100 schools here, and you started thinking about the syllabus very creatively. So that way, maybe public health in Kerala may be liberated, saved, quote unquote, by the professional social workers, looking at health critically, applying the critical lens, applying the values of equity and justice. And I conclude saying that probably this may, the principal and manager, Achin, maybe look at the issue of looking at public health as an integral part of social work practice in terms of syllabus, in terms of practice, in terms of conceptual ideas, and also creating an education opportunity. Thank you very much.
Thank you, sir, for the insightful and thought-provoking keynote address.